Hi, my name is Dr. Derek Lee. Today I'd like to introduce orthopedic or pediatric orthopedic surgeon, a pioneer in non-fusion scoliosis surgery, specifically VBT. And he's also the chief of surgery for Shriners Hospital in Philadelphia, Dr. Amer Samdani. Welcome, doctor.
Great, Derek, thank you so much for having me.
Okay. Now, I'd like to go back a couple years to your youth. Did you always want to be a physician, or was that something that occurred later in life?
You know, Derek, I'd say when I was growing up, it was definitely something that I looked at and considered as a career. But much like many other kids growing up in Brooklyn, New York, you know, there were times when I would want to be a baseball player or a fireman or a pilot. But I'd say, especially as I started getting into high school and college and did some volunteer work at hospitals, that it really started reinforcing to me that this was the career path that would best suit what I wanted to accomplish.
Very good. Now, you completed your residency in neurosurgery at Johns Hopkins Medical School in Baltimore. Was that I guess that's the initial field you wanted to get into. Is there a diversion in there somewhere that?
Oh, great. It's a great question. So, you know, I did my residency in neurosurgery at Johns Hopkins. That was in the late 1990s, early 2000s. And at the time, Derek, you know, spine was really in the purview of orthopedics. But at that point, neurosurgeons were just starting to get involved in doing spine procedures, but mostly on the adult side. There really wasn't any influence on the pediatric side. So I actually continued within neurosurgery, but then eventually went down a path that has traditionally been with pediatric orthopedic surgeons. And, you know, I was very blessed to be able to find the right mentors like Dr. Betts and others who really felt that we could push the field forward if both neurosurgery and orthopedics worked together.
I'm glad you brought up the mentorship because everyone has a bit of a story in terms of their greatest influences and in terms of their career path and the journey they want to embark upon. You mentioned Dr. Betts. Were there others, including Dr. Betts, or was Dr. Betts initially the one that was motivating you the most?
Yeah. So, you know, I'd say in residency, there was a Dr. Zia Gokazlan, who was the big spine surgeon. He does a lot of tumor work at Johns Hopkins, and Dr. Henry Brem, who's still the chairman there. And just the way that they lived their lives, both inside the operating room, the care that they showed in the operating room in the hospital, but also outside of the hospital, just served as great mentors. Randy was, you know, Betts is obviously a very close friend and a real mentor in this field because he was very broad-minded. You know, there were people felt that perhaps neurosurgeons should not be involved in this space. But Randy, again, had the vision to say that, listen, we can be better if we work together. And he hired me back in 2005, and I've been at the Shriners Hospital since then.
Was that the initial drive to be at Shriners, to be mentored by Dr. Betts, or?
It's a great question. So, you know, my initial drive was twofold. Dr. Betts was a giant in the field at the time, and clearly I wanted the opportunity to work with him. Actually, the way it happened was, it's an interesting story. It was summertime, and I was doing my fellowship at the Children's Hospital of Philadelphia, and Dr. Betts was doing a course at the Shriners Hospitals, like we do today, you know, teaching courses.
Okay.
And it was the summertime, so they had a hard time getting enough surgeons to participate in the course. So they came over, and I was still training at the Children's Hospital of Philadelphia, and said, hey, listen, can you please come to this course? Because, you know, we need people. We have a great faculty. So I came in to the course, and I'll never forget, he did a spinal fusion that day, and I was just awestruck. You could take a spine that's crooked at the beginning of the day, and at the end of the day, you have yourself a totally different child and spine. And that was really the start of my desire to want to come to the Shrine, work with Randy Betts, and then ever since I've stayed there.
That's another question I have for you, because sometimes there's a little bit more movement with surgeons as they you know, go to learn new techniques or influenced by different surgeons. what were the reasons that you remain at Shriners? And it does seem as well that just talking to other surgeons that there's a bit of a very close-knit group within Shriners that's might not be replicated throughout different hospitals.
Yeah, Derek, I can talk about the Shriners forever. I mean, I am a huge fan and believer in what the Shriners stand for. We get the opportunity to take care of children with no regards, it doesn't matter what their socioeconomic status is. And not only do we get to take care of them, we get to take care of them with the most cutting edge technologies in a really, really high level of care. And the thing that I love about Shriners, it's really the way I envisioned I would practice medicine when I was in high school or college. And as I went through residency, I see a child, I have no idea what their insurance status is, what the economic background is. I get to make a decision solely on what I feel the timing of a procedure should be and what that procedure should be. And that feeling of independence and the people that the Shriner draws in, from our therapists, our nursing staff, my colleagues, everybody in the hospital, just makes it an extremely special place.
And I can vouch for that, because as soon as I walked into Shriners Philly, I was completely shocked with the personnel, the staff, and the level of technology that's there. It's quite incredible.
Yeah. Okay. If I may expand on that a little bit, obviously, you know, there's growth modulation work that we do, but prior to growth modulation, back in 2014, there were these magnetic rods, so-called magic rods, where you could save a child up to 10 or 12 trips to the hospital, to the operating room, because you can lengthen these in an outpatient setting without surgery, without any incisions. And the Shriners, once the FDA approved it, was the first hospital to put those rods in. And to this date, we are one of the highest volumes for those rods. Some of the other hospitals, my surgeon colleagues struggled because the hospital saw the rods as a big expense. And they did not want to, at the time, insurance wasn't reimbursing hospitals. We didn't have to deal with any of that. I mean, the Shriners felt we had to do what was the best thing for the child.
That's incredible. And to be honest, I didn't have a clue about Shriners before I started investigating the hospitals, and I still can't believe their generosity. It's incredible. If I go back to a little bit with Dr. Betts, Dr. Betts started out with growth modulation in terms of VBS, vertebral body stapling. And were you involved at that point in the progression of two VBTs?
Yeah, so when I started, I mean, Randy is a pioneer. He's always thinking, you know, how can we do things better? And, you know, that was his motivation for this. He had done a lot of animal studies, you know, on goats and pigs with staples. Once he felt it was safe and there was opportunity for efficacy, he translated that to patients. And I came in about halfway through the vertebral body stapling, and I did perform vertebral body stapling procedures. And for a set group of patients, it worked great. But what happened is it really worked best in curves that were less than 35 degrees. And as we know, once bracing, the BRACE study came out in 2014, published in New England Journal of Medicine, really showed that bracing actually works very well for that same curve pattern. So that's why vertebral body stapling lost some of its popularity.
Very good. It seems that with the FDA study for VBT, were you involved in organizing that with and teaming up with Zimmer? How did that actually come to be?
Yeah, no, Derek, great question. So I learned a lot through this whole process about what it takes to get a device approved. And obviously from the FDA's point of view, they want to make sure they protect patients. And they're doing the right thing. They want to make sure there's data, there's protection, that there's really high class and high quality data that will base their decisions. Industry then has to decide, are they willing to fund those studies? And initially, those studies, they can cost anywhere to 20, 30, 40, $50 million
Hmm.
and can take 5 to 10 years to complete. So the question becomes to industry is, will the device still be relevant by the time this study is completed?
Right.
So clearly, especially in the pediatric space where the numbers and the volumes may not be as high, where the payoff for industry's perspective would justify such a large cost. So to the FDA's credit, they really modified their requirements, still keeping safety as a really high bar, but they did not require these very expensive studies. They allowed us to modify the studies and utilize real world data to help inform their approval.
Were you involved in setting the initial parameters for using?
Yes,
Okay.
yes, certainly it was, but certainly I was involved in it. I had a lot of input, but it was a multi-person, multi-institution effort. The Shriners played a huge role. I think the Shrine, if they weren't so generous, I don't think we'd have an approval right now, meaning if they didn't allow us to do procedures without getting reimbursement from insurance companies, it's likely that this field would still be delayed, because the data that came out of the Philadelphia Shriners is what formed the basis, Derek, for the approval. And myself, my partners, Josh Pays, Steve Wang, Pat Cahill, obviously Randy Betts, and then the Shriners were all involved in that long, arduous process.
Now, I spoke to one of your, he was saying he was one of your first residents, Dr. Bob Cho.
Of course,
And,
of course.
And he talked to me a little bit about the process of becoming certified to do VBT, and with Zimmer's support. Were you also involved in kind of the training techniques? Because I do know you train, you demo surgeries for visiting surgeons, correct?
Yes, Derek, absolutely, we do. It's myself. There's probably 8 surgeons now that are part of the training process. And to Zimmer's credit, they didn't, once they had the approval, they didn't just put the device in all of the surgeons' hands and said, hey guys, just use the device as you see fit, as long as we're selling our device. They are, to their credit, very stringent on giving the device out. They will not give it out until you've completed a training process. So I do commend them for that.
Okay. Before I move on to other topics, since we're on Zimmer,
Yeah.
we always get asked, or there's always questions with respect to parents, and is there going to be a new Tether coming out that's a little bit stronger? Is that on the horizon?
Yes, Derek, I think absolutely. It has to come out. I mean, we have gotten so much better with materials. There's no reason why it's not going to come out. So, the question really is, why hasn't it come out just yet? Again, the FDA requirements for a new substance being put in, the current tether has been put in for the last 25 or 30 years. There's a good understanding of biocompatibility and biosafety. But there is, I know for a fact, multiple companies, Zimmer Biomet that has the approved device, Globus that's working on one, Medtronic, J&J, everybody's working on a different device. And I know they're all looking at new material. And I would be disappointed, quite honestly, if we did not have a new material come out within the next 3, 4, 5 years at the latest. I mean, I'm certainly hoping sooner than then. Again, it'll just depend on how that approval process goes. That will be a leap without any doubt.
Can't wait.
Yeah.
I'm sure a lot of people can't wait. Now, I've heard that also that Zimmer has kind of modified their current tether, so there are markings on it for screw placement and to help with tensioning and ease of entry into the chest cavity and all that. But they haven't really increased the strength of the tether per se.
Yeah, you're absolutely right. I mean, the system has been designed myself. There were, I believe, 5 other surgeons that were involved with Zimmer. There's probably another 25 surgeons working on different design elements on different systems, maybe 30. Just trying to improve the process. I think it is important. We've gotten it. We can do it well, but there's still areas that I think we can improve on.
Okay. Do you expect parameters to increase at all, or this is kind of what it's set for because that's what the FDA accepts as safe?
Yeah, Derek, great question. So, the FDA will base their parameters, which is curves between 30 and 65 degrees in idiopathic scoliosis, based off of the data, but it's still up to the surgeon to decide who the optimal candidates are. And that's why you see variability in who's doing, what with respect to indications. So that would become then an off-label use. It's very important for families to know that they would be in that off-label category. But this is not uncommon in medicine, is to have something that's, indicated for a certain procedure or a certain disease entity, but to be utilized in another for another disease. I mean, you can look at all the different medicines that are given to put children to sleep. There's very few that have actually specifically been approved for children. They're just correlating it off of adults. And even spinal implants, outside of the tether are approved for certain strict indications, but surgeons can expand those indications in a surgeon-directed usage.
Okay, there is flexibility, especially with experience levels, I guess.
Yes.
Okay. For instance, with the AIS, it's idiopathic. But once the scoliosis starts to roll, there seems to be more consensus that perhaps anterior vertebral wedging, anterior vertebral overgrowth causes a wedging from the anterior to posterior that drives hypokyphosis. The spine tries to release tension by going into rotation, and that's how the coronal scoliosis curves start to progress. Is that correct?
Yes, Derek, that is exactly our understanding, that adolescent idiopathic scoliosis is really an anterior overgrowth phenomena.
Okay.
So many patients will have, instead of kyphosis, will have lordosis in their spine because the anterior column is overgrown. Many times the two-dimensional X-ray will not pick up that lordosis because it's a two-dimensional X-ray of a three-dimensional deformity. But without a doubt, there is anterior overgrowth.
One question I had for an orthotist, and he hadn't really thought of it before, is that if we know that the progression of a curve is due to hypokyphosis, is it possible to brace at an early stage before the scoliosis is increasing into more of a kyphosis, and thereby taking advantage of bone modulation at the anterior edge of the vertebra to make a difference?
Absolutely. I feel that we can try to modulate the spine without surgery, without a doubt. And there are patients that are braced at very early ages who will show correction of their curvature, but it requires very aggressive bracing. And it has to be a three-dimensional correction, Derek, just like you're saying. You want to really correct the spine, especially if there's a sagittal plane or a lordosis, the view from the side. You want to try to get bracing to get it early on. Without a doubt, we're firm believers.
Have you noticed any bone modulation with respect to tethering in the sagittal plane?
Yeah, it's a great question. So Peter Newton has done work in this space, really looking at the vertebrae and their wedging, and without a doubt, the vertebrae will go ahead and remodel in 3 dimensions. In my practice, I would say there are times that I see children who will modulate in the sagittal plane, and other times that they don't. It's rare for me to see them worsen. I don't think I've seen a child that I did a tether, and if you really critically look at it in 3Ds, that they actually worsen. Usually I'll see some correction, especially if we were to look at it in 3D, but certainly not any worsening.
Okay. And that's why when we had talked about my son's hypokyphosis, you mentioned that sometimes it works, sometimes it doesn't, because it depends on in individual cases, correct?
Yes, depends on it. And Derek, we've gotten better at trying to make it work now. Earlier on, I think our screw placements, we picked up these little nuances that we feel, time will tell if they work, but it seems that we've picked up some nuances to help us to make it work.
right? In terms of screw placement, like you said, and helping rotation and different
Exactly
axes
right.
of tension. Okay.
Exactly right.
One question I had as well with respect to tethering is because you're going into hypokyphosis again and rotation, and that's progressing the coronal curve. When you try to derotate and reduce the hypokyphosis, which the tethering can do to a certain extent, are you kind of reloading that spine, that spring?
Mm-hmm.
And is it one reason you tend to shoot for maybe a 50% correction initially because you don't want to go too much to zero?
Yeah. So absolutely, we're reloading the spine. We try not to overcorrect the kids because when we looked at our cohort, the number one reason for reoperations is overcorrection.
Mm-hmm.
And it really depends on how much growth kids have left. Usually boys grow for a longer period of time. We feel that if we're left with a curve less than 30 degrees at the end of skeletal maturity, that's going to be a good result. Obviously, we want to make sure in the sagittal plane that we have not certainly worsened anything, hopefully improved it as well in the sagittal and the axial plane. But typically, we will leave some curve in the spine because we're anticipating with growth, we'll see some level of correction.
Mm-hmm. And what Sanders score would you estimate to be the perfect VBT candidate?
The perfect, I would say, is probably between a Sanders 3 and a Sanders 4. I think if you're too young, you're going to overcorrect. I think if you're too old, too mature, Sanders 7 or beyond, in our experience, you're probably not going to correct enough. Between a Sanders 3, 4 in that range, there's some 5s actually, because the Sanders stage certainly gives us a piece of information, but we look at the entire patient. If it's a girl, if they've had their menses, parental height. Boys generally tend to model their bones for a longer period of time. So those are all different factors that we look at.
Do you kind of target in those parameters a 50% correction, and you hope for about a 25% correction for overall 75% by the end of maturity?
Yeah, so the main thing that I think about now is how can I accomplish the first goal, which is avoiding a fusion. Second goal is to do it with the fewest number of operations.
Mm-hmm.
And then if you're left with whether it's a 28-degree curve or an 18-degree curve, I think probably doesn't matter too much, although we obviously want to try to maximize our curve correction. But it is unpredictable because there's some patients that will correct 50%, Derek, and then they'll stay in that same range. Usually for a year, it doesn't change. And then all of a sudden, they're going to correct out and straighten the spine out completely.
Okay.
The problem is some of those patients will then also have a chance of overcorrecting. There's others that we correct 50%. They're down to 25, 20, 25, 30 degrees. And even though they grow, they end up not changing their vertebrae as much.
Mm-hmm.
But even still, if they're left at the end of maturity with that curve less than 30, I'm certainly happy with that.
Absolutely. Compared to a 50 or 60 degree curve. Absolutely. There's a controversy about disc release.
Yeah.
Right. And I guess I did speak to Dr. Betts, and the rationale is that you have to kind of reduce the anterior column and actually make space to accommodate the derotation and then improving hypokyphosis to get a better correction, and more so for mature spines, right? Yeah. How do you feel about that?
We've been very conservative with disc releases. There are some surgeons like Dr. Betts, I believe maybe Dr. Lahner, that are doing it. So if there's 25 or 30 surgeons in the United States that are doing this, I'd say there's probably a handful only that are doing disc releases that I'm aware of right now. The main concern that we have with disc releases is, are you, by cutting the disc, essentially going to cause the disc to fuse or cause pain later on? Now, my hope is that doesn't happen, but that's the concern that we have. So I would love to see that data, and data will certainly convince us. 3, 5, 7 years out as they go through, because I think the data should be coming out. And I'd like to keep an open mind. I'd love to see how those patients are doing. Did any of them have pain? Did they actually auto fuse across the segments that were cut? And then I would certainly be open to it. But the concern that myself and the majority of surgeons that do this is, if you're going to cut the discs, are you essentially doing a fusion across those levels? And are you setting the child up for potentially pain?
When parents basically say bye to their kids as they're headed into the operating room, we just see both ends, pre-surgery, then we see them in the PICU.
Yeah.
Can you kind of take us through what actual surgery is like in
Sure.
terms of what happens from that point on?
Sure. So, when you say goodbye to your child, I mean, that's a scary moment. And, it's interesting when I see parents, and, I have 4 children myself. So I have some sense of what that would feel like, but it also shows me how privileged we are to be being trusted with your most prized, people in the world. So, and that's really the overlying concept that we have. And what that means is, when we come in, everybody's focused. We want to make sure we don't avoid any catastrophic mistakes, such as wrong side surgery, wrong level surgery, level up and down, not as catastrophic, some wrong side surgery. So we have a bunch of checklists set up that will avoid that, and we've never had them happen. And the child will come in, our anesthesiology team and the nursing team will greet them, try to calm them down, and they'll go off to sleep pretty quickly after that point. There'll be about 8 people in the room. There'll be 3 nursing staff members, there'll be 2 anesthesiologists, there'll be 2 to 3 surgeons, probably 3 surgeons, so actually more than 8, and there's a neuromonitoring person in the room as well. And everybody's focus will be on making sure at every step that the child is taken care of. And we encourage an atmosphere of everybody being able to speak up. And we will emphasize that in our operating room. If there's a concern, you're going to speak up. We will generally not be having any conversations other than if they're related to that procedure. Then after the child is positioned, we clean them, and then the surgery is started. Usually our general surgeon is working with us at this point, getting the spine exposed so we can place our screws on the tether. We place our screws, our tether. We're very meticulous about making sure at every step that we're checking neuromonitoring, because of any risk of spine surgery is paralysis, and we've not had any spinal cord issues. Then we check our screws with a little O-arm spin that really lets us see the screws in 3 dimensions, because we want to make sure that they've been placed optimally. After that, we tension. And then once we've tensioned, we irrigate the blood products out. The anesthesiology team has deflated one of the lungs so we can take a good look at the spine. They reinflate that lung, and then we close up and ask our child to move their feet prior to leaving the operating room, and then they're taken up to the ICU.
See, I didn't know the child gains consciousness in the operating room.
Yes.
Okay.
Yes.
Okay.
Just for a couple of minutes, so we can confirm that they're moving their feet.
Well, it makes total sense.
Yeah.
Do you have any stats with respect to the breakage of tethers in terms of the frequency? Because there seems to be a bit of a debate with that.
Absolutely. So, I would say that probably 30 or 40% of patients will have some degree of breakage in their tether. Rarely will they even know it. Rarely will, until we see it on an x-ray, which typically manifests as the screws, which will have a certain angle relative to each other, that angle changes.
Mm-hmm.
I can tell you that to go back in for a tether breakage is extremely rare, unless there's significant loss of correction, which again, with a single level break is unlikely. If a child is done growing, I would love to see the tether break in many places as possible, quite honestly, because that to me means that we're left with a child that's not going to have a fusion, and whatever little limitation the tether may put on their mobility is taken away because the tether has broken. So it's not uncommon. If the child's vertebral bodies, like you were saying earlier, have modulated and are more symmetric, even if it breaks, you may not even see it or know it because the screws won't splay at all. They'll splay a bit if the bodies are asymmetric, and there'll be some loss of correction, rarely requiring a reoperation.
Okay, that's pretty fascinating. There's a couple points you brought up there, and I like the idea when you said you wanted to actually break eventually, because has there been a bit of a correlation between a mature spine being tethered and greater likelihood of fusion?
So in our cohort, actually, because we don't do that many mature spines, and I haven't seen literature from the other centers, and I'd love to see it at 5 years, the number one reason for reoperation is overcorrection. The tether actually, so if our reoperation rate, let's say, and again, it's going to go down over time as our techniques have improved, but from early on is 20%. I'm just going to say 20% of the time you go back in for some reason. About 70% of that is for overcorrection. Okay. Especially early on, we were really tensioning the tether too tight. It was too straight, and then it goes the other way, and we have to cut the tether. And so with maturity, the concern is that that rate would be higher, meaning the tethers may break and you may have significant loss of correction, but I don't have any data on that, Derek.
Sure. Okay. No, it's just an interesting angle. I haven't heard that one before, but I haven't heard a lot before either. The question I had as a follow-up is that if you're seeing a 30 to 40% tether breakage, and it could be just at one level, and it doesn't mean that it's rare to go in to do a revision. What is your current revision rate at?
Yeah, so right now, if we look at our patients, we've done operating on more than 500. I would say that, and again, if we look at our first 100 patients that are 5 years from surgery, and the reason why I say 5 years in scaly mature, because we feel it's unlikely that they would need additional revisions after this point because they've been followed up.
Right.
Although we're not 100% sure, it's about 20%, with the vast majority of them being for overcorrections from our earlier patients that we overcorrected. So I know for a fact if we look at our last 100 patients, once we have them 5 years out, there will not be as many overcorrections, so our overall revision rate will decrease.
Okay, so that's pretty interesting that it's actually the overcorrection that causes the revision as opposed to the tether breakage at this point.
That's the number one reason for our cohort, Derek, yes.
Okay. I think most tethering surgeons tend to use a single tether in the thoracic area and possibly a double in the lumbar just because of the amount of forces in those areas. Is that correct?
Yeah, I would say the most surgeons probably still use a single in the lumbar, but I am starting to see more surgeons consider it. And I think, to me, I'm not as opposed to that. I just want to understand what the biomechanics of having that second tether in there will mean. Meaning, will the spine get so rigid that it actually fuses, auto-fuses? I don't think that'll happen, even with a second tether. But I am not aware of the biomechanics behind adding another tether. Does it end up simulating maybe a small rod? And again, I would just want to study that before I did that in any consistent manner.
I think some surgeons feel that it's to perhaps add additional support so it reduces tether breakings in the lumbar area.
Yep, and I would suspect that it does.
Okay.
The question is, does it come at a cost of limiting mobility? My gut says it doesn't, but I would love to see some data.
Yeah, because of course it's going to restrict the flexibility if you double up.
Exactly right, Derek, exactly right.
My last question for you, Dr. Samdani, is you've been there as a pioneer at the beginning with VBS, then VBT, then there's ASC. What do you see as the next step?
So, there's clear proof of principle here that for the right patient, you can have a spectacular result. We have to try to now firstly get more and more patients into that spectacular category. And that's going to come through understanding how much to tension. It's going to come through understanding what age to go in at. And there's work being done looking at this. It's going to go into understanding what we're doing in 3 dimensions, Derek. I think you brought up some great points on that. And it's going to go hand in hand with some incremental improvements in the materials that we have. For example, a better tether. So that's what I see over the next 2, 3, 4, 5 years. Eventually, I would love growth modulation to be able to be performed not from having to go through the chest. Perhaps we can find a material or a method to be able to still go from the back of the chest to the front of the chest. As we've gotten better with navigation, robotics, all these things will play in. That's what I would love, is I would love to be able to do that from the back, but we're still a ways away from that.
That way you wouldn't have to have any involvement with the lungs, which are always a problematic area with scoliosis.
Exactly right, Derek, exactly right.
Dr. Samdani, thank you very much for your time. I appreciate it.
No, it was my pleasure. Really, really enjoyed this.
Okay. All right. Thanks very much. Appreciate
Anytime.
it.
Thank you. Bye-bye.
Okay. Bye-bye.